Remove this hard disk.
A very good evening, dear all. On behalf of Indian Society of Cleft Lip, Palate and Craniofacial Anomalies, I welcome you all to the third webinar of Dr.Ashit Memorial series of the webinars. So today we'll be discussing about the cleft orthodontics, be it pre-surgical nasoalveolar molding or treatment during the mixed dentition or orthognathic surgery. So we are having a galaxy of renowned speakers on the panel. I request our president, Dr. Krishnamurthy Boranthaya, to please introduce the panel.
Thank you, Atul. It gives me great pleasure to invite all of you to this orthodontic webinar, the third in the series of the Edenwala Memorial webinars being conducted by the Indian Society for Cleft Lip, Palate and Craniofacial Anomalies. Like Atul mentioned, we have a fabulous set of speakers here who are with us today to share their knowledge. This program will be moderated by our immediate past president and member of the Dental Council of India, Professor Puneet Batra. He doesn't need any introduction to the orthodontic scene. He's a prolific orthodontist with a lot of focus on cleft orthodontics. He's also a member of the Medical Advisory Board for Orthodontics in Smile Train, and he's also a vice principal in one of the colleges at Delhi. We also have in the order of presentations, Dr. Renu Parmar. Renu Parmar is an orthodontist who works almost exclusively on cleft orthodontics. She's part of our team at the Bhagwan Mahavir Jain Hospital at Bangalore. Then we have Dr. Ashit MV. Ashit is a very vibrant, very enthusiastic orthodontist from Mangalore. He works with the Manipal University at Mangalore and is an innovative orthodontist, always bubbling with ideas. We also have the one and only Maria Costanza Meazzini, who is an orthodontist known all over the world for her wonderful and innovative work, always keeps us surgeons on our toes with some lovely research that she carries out, and has been a beacon to look forward to listening to. Welcome, Dr. Costanza Meazzini. And we also have, today it seems like we have women in full strength in this panel. We also have Dr. Pallavi Daigavne, who comes from another big university in India, from Wardha. She's also an orthodontist who has done a lot of work on cleft orthodontics from the central India, and has some lovely presentations and publications to her credit. So without wasting much time, I welcome all of you panelists and moderator to this meeting, and hope you have a successful deliberation. Before we actually go into today's webinar, I have a rather a sad duty. This is happening now again and again in the short period that I have been the president of the Indian Society. It's my unfortunate duty to bid farewell to one of the giants of the international cleft scene, Professor Ian Jackson, who was one of the pioneers of cleft and craniofacial surgery the world over, passed away a few days ago. Ian Jackson was not a stranger to the Indian craniofacial surgical scene. He was a Scotsman who was a pioneer craniofacial surgeon, along with Derek Henderson and Khurshid Moose in England, in Scotland, at the Canisburn Hospital, and then moved over to the US. Had a huge impact on training hundreds of cleft and craniofacial surgeons from around the world. Many of the well-known craniofacial surgeons in this country, including Dr. Ramesh Sharma, Dr. Karun Agarwal, Dr. A.K. Singh, the big names of Indian plastic and craniofacial surgery, were trained by him. He was no stranger to the Indian scene as well, visiting us a number of times. In fact, I once heard Professor A.K. Singh from Lucknow, tongue-in-cheek, calling him Professor Ian Jaikison, because he said he was so Indian. He was not only a great surgeon, a very prolific researcher, but also a great humanitarian who made his name with great work, pioneering so many different things. For example, the LeFort 2 osteotomy was originally called the Jackson-Henderson procedure. Right from those days, Ian Jackson has had a huge impact on the cleft and craniofacial scene around the world, and we lost him a few days ago. Please join me in wishing heartfelt condolences to his family and also his friends around the world. Thank you. I now hand over the proceedings to Puneet Batra to start with the actual webinar. And I welcome the more than 200 participants who are already here. Thank you.
Thank you, Dr. Krishnamurthy, for this wonderful prelude. And at the onset, I'd like to thank you, sir, for being so inspiring. And at this time, when the cleft world has suffered such a big jolt, the four big pioneers, big names in cleft world were lost in this time. We lost Dr. Jyotsna Murthy. We lost Mr. Satish Kalra, who brought Smile Train to India. We lost Professor Dr. Edinwala, in whose memory we are doing this webinar series, and Dr. I.T. Jackson. Well, as a prelude, I'd like to say that our president, Dr. Krishnamurthy, made it a memorial webinar series for Dr. Edinwala. For orthodontists who don't know, Dr. Edinwala was born in 1930, and he finished. He from Mumbai. He moved to a very small hospital in Thrissur, the Jubilee Mission Hospital. And from there, that man left his life and soul. The Joseph McCarthy Award for Excellent Medicine, a Lifetime Achievement Award in the Kerala chapter of the Association of Plastic Surgeons of India, and the Plastic Surgery of the Year Award by the Association of Plastic Surgeons of India. He was the member of the Medical Advisory Board of Smile Train New York and member of the Medical Advisory Committee Smile Train India. A great human being, he was a man who we all will remember. He passed away on 27th May 2020, and in his memory, these webinars are being conducted. I would not take more time, but tell you that there are four speakers for this webinar. We will start with Dr. Ashit, MD, who Dr. Krishnamurthy has already introduced, an associate professor from the Department of Orthodontic, Manipal College of Medical Sciences, Mangalore. Dr. Ashit, please share your screen and start your presentation. Dr. Ashit. Dr. Ashit, please.
Yes, sir, I can hear. I am sharing. Yeah, very good evening, everyone. I am Dr. Ashit. I'm an associate professor in Department of Orthodontics, Manipal College of Dental Science, Mangalore. Today, my topic of presentation is nasoalveolar molding. I would be talking more about a few of our own modification techniques which we use for nasoalveolar molding, especially for treating unilateral. And I would cover one or two cases on bilateral also. As we all know that cleft of the lip and palate is one such condition that occurs at such a strategic place in an orofacial region, and at such a crucial time that it always becomes a very complex congenital deformity. So it was Matsu who thought that the cartilage can be molded. From this article, what you can see, the idea of tissue expansion and tissue molding, they came to know by this Matsu's article. That's how the idea of nasoalveolar molding, which started, and it was introduced by Barry Grayson in 1993. So what usually happens during a nasoalveolar molding? The increased level of hyaluronic acid which is there, which inhibits the cross-linking of the cartilage in the intercellular matrix, which will also increases the plasticity of the tissue and cartilage, which will help the molding possible. So we are, if you see this, we see India is a developing country where the proportionate cleft care specialists who are working in this uh, unit are like less in number, and we might have patients need to travel a longer distance to reach their specialist for a better treatment outcome. So whatever technique today I am going to speak, they are mostly we have considered all these factors, or that it should be simple to use, it should be inexpensive, and less time consuming, which can also reduce the frequency of visit, because the patients what we get usually they have to travel a longer distance. So coming every 15 days would be difficult. So we have come up with this formula for treating cleft cases. This is a chart which we use for unilateral and bilateral cases. So we have divided into two types of cases which we have. One is a typical cases, that is typical unilateral and typical bilateral. And there is the other set of cases which are atypical cases. So these cases which will have an incomplete cleft lip with good sucking reflex, or a complete cleft with a good sucking reflex, patients with medically compromised, or patients with ulceration, neonatal teeth, or semonite band. So for any cases which comes with the uh, typical cleft problems, we usually use a single stage nasoalveolar molding technique, which we have named as INAM, which we have a study with Puneet sir, which we have published. I will be talking about it. And for a typical bilateral case, what we usually use is a 3D Versa screw, by which we can mold the premaxillary segment three-dimensionally to get a better treatment outcome. All other cases, we use an atypical, we call it as an atypical case. So these cases, we use something called as a mu hook. Mu hook is named after Manipal University. So the first thing is a single stage innovative nasoalveolar molding technique called as INAM. These are the armamentariums which we usually use for INAM. But what we see different from the regular NAM is a beta titanium wire, which you can see. We don't use a stainless steel wire. Instead, we use a beta titanium wire. So the stent which we use are used on the first day itself, and we do something called as a predictive arch forming. So once the primary impressions been taken, then what we usually do is the wax. We use the wax for taking this primary impression, and the same wax can be used as a spacer. So that can save us some time. And on that wax spacer, we use it to make our secondary impression, and that wax can be used as a spacer in the secondary impression. So once that is done, we do something called as a pre-predictive anatomic arch form. So on that, the appliance is designed, and the appliance, once the appliance is designed, the wires are incorporated, stents are adopted for nasal molding on the first appointment only. So this is how the appliance will look. It has a soft acrylic lining on the nasal hook, a beta titanium wire. Why we have used beta titanium wire? Because it gives a long range of action, and it is more flexible. The range of action is for a longer duration of time, and it can be easily molded, and an acrylic place, as you see in all other appliances. I would like to share this first case of INAM. This patient who has come at the age of 9 days to us, and the weight of the child was about 3 kg. So this is the pre-treatment pictures with the collapsed uh, nostril on the cleft affected side. So once the molding plates have been given, this is the molding which has occurred in the first 6 weeks. So we see the patient once in 6 weeks, because that is the advantage of using a beta titanium wire. The larger range of action, and we can also reduce the frequency of visit with this. So this at 84 days, you could see the weight of the baby is about 4 kg 800 grams, and we could achieve a good nasal molding also with a good alveolar repositioning. That is the post treatment picture, pre and post treatment comparison. You can see the amount of alveolar molding which has occurred. It has reduced from 14 millimeters to about 2.5 millimeters. So this is the second case which we have got. The weight of the baby was about 3 kg 200 grams. So the pre-treatment picture, we have got this baby at around 14 days only, and this is how the appliance, you can see the appliance. You can see a U loop in the design that is used for adjusting the nostril, used for the nostril adaptation, nasal adaptation. Sorry. So the mid treatment, you can see the amount of nasal and alveolar molding. So this is how the baby finally looked post treatment, and this is the pre and the post comparison. So there is good amount of alveolar molding also, from 11 millimeter to about 1. It has reduced to 1.5 millimeter. So the case was operated by one of the eminent surgeon, Dr. Mustafa, and this is the outcome of the case post surgery. This is the pre and post result. This is the study which we are talking. So we went on to compare the results pre and post by doing a 3D scanning, and used the Polywork software to see what is the amount of changes which has occurred. So we have seen there is, and we have compared this single stage to a Berry Grayson's technique. So what advantages we saw in this single stage nasoalveolar molding is the primary impression which we take by the wax, that wax becomes a spacer for secondary impression. One is a single stage technique. So nasal stents are incorporated on the first day, and use of beta titanium wire reduced the frequency of the visit, and it helped in increasing the duration of action for a longer time. So it has a low, one of the advantage of beta titanium is it has a low modulus of elasticity, greater spring back, good corrosion resistance, and it ductability and formability is feasible to give loop and bends also. That is why we have used beta titanium wire. So this is the study. You can see the outcome of the study. This is the study which we have done with Dr. Puneet sir. So we have found out in both the technique, we have compared pre and post and superimposed, and the outcome is the alveolar molding in patients unilateral cleft lip, alveolus and palate, both in Grayson's and the single stage nasoalveolar molding is almost similar. So the same, we have a modification for bilateral typical cases in which we have incorporated 3D screws for molding. So what this usually does is, once the impression is taken, then the 3D screws were positioned in such a way so that we can mold the premaxillary segment if there is any rotation. So you have to just off center the 3D screw and place it in such a way so that you can get adequate movement of the premaxillary segment. So this is the appliance design. It has a 3D screw. It has two acrylic bulbs. It has a retentive arm, and it has two acrylic plates which will help in uniform distribution of the forces. So you can see it here, the alveolar segment. The first case, it is a non-syndromic bilateral cleft case, which we have got at 15 days. We have designed the 3D versus screw appliance, and we have given it to the patient. We have an activation protocol which we follow. That is 2 quarter turn per week. So what usually happens when we do that in bilateral, we see the lateral segments are a little collapsed compared, and the premaxillary segment is outward usually. So what happens is you need to expand those lateral segment and get the premaxillary segment inward. That is what we are doing with the help of this 3D versus screw. So what usually happens when we activate, anteriorly we have kept the screw in an open mode, whereas we have kept the posterior screw in a normal closed mode, which will help in the expansion of the posterior segment. And anteriorly it will try to mold the premaxillary segment backward. So this is the activation segment. Frontal activation we do once a week quarter turn, and backside we do twice a week quarter turn. So this is the activation schedule which we give it to the patient. As and when they activate, they have to write the date with it. So what is the advantages of using a 3D screw is that it will move the premaxillary segment in the same way, and it will reduce the extrusion of the premaxillary segment. That is why we have used this 3D screw. So you can see after 6 weeks, the premaxilla has centered, and this is how the baby looks, and that is after 12 weeks, just before surgery. You can see the amount of changes pre, mid, post. There is a good amount of columnar lengthening also, which you can see. So this video you can appreciate what has happened over last 12 weeks. So we have marked all the pictures which we have got at different visits, and you can see the amount of alveolar changes and the increase in the columnar length. So in the cast, if you compare, you can see anteriorly you can see the amount of expansion which has happened is about 4 millimeter in the intercanine region, and in the intermolar region it is less. So it is only about 2 millimeter. So we have again we went on to do a superimposition on the pre and the post model. What we have found is by the lateral segment, we have not found any extrusion in the premaxillary segment. In fact, we have got it a little bit of intrusion instead of extrusion, so which is favorable. If there is any extrusion in the premaxillary segment, so the incisal show once the child start growing will be more. So that is the advantage. So what advantage we have, once the patient comes into our hospital, we train them how to use these appliances. We train them how to activate the appliance, so they need not come every 15 days for activation. Once they are trained, we tell them to stay there for 1 or 2 days till they are well versed with the activation technique, and then they can go home and do the activation on their own. So thus it reduces the visit to the hospital. There is a controlled retraction of the premaxilla. There is a minimal or no hemorrhoid bending. There is significant columnar and vestibular lengthening, and simultaneously there is anterior constriction which is there, which can be expanded, and the premaxilla can also be brought back to the normal position. So the last technique which I would talk is a mu hook. So it is this is what we have published in Journal of Contemporary Orthodontics. You can there are few case series in this. There are about 5-6 different case scenarios which you can see. Why we thought of doing this is because we had a lot of patients with cardiovascular problems who are coming in, for whom we couldn't do nasoalveolar molding. We had patients who had poor oral hygiene after birth. They had ulceration. They had neonatal teeth. Some patients where giving a plate is very difficult. We had patients with lip alveolar adhesion due to Simonite band. So the movement of the alveolar segment was a little difficult by giving and giving a plate also would be a little difficult. So those cases either we should not treat those cases. And treatment would have been very difficult with the regular nasoalveolar molding. That is why we had to do an appliance which is simple to use, and we would get some good treatment outcome also. So you can see this. This is one of the cases which we have got, which has a neonatal tooth. The first case. The second case had an ulceration. So giving the plate would have increased the tissue irritation, and wound healing would also delay. So that is why we went on to plan for mu hook. The second is a semonite band, which you usually see a connection between the uh, nasal alveolar segment. So again, in few cases we don't have to do a alveolar molding. Just a nasal molding would be enough. So that is why we thought mu hook would be better. So this is the mu hook design which is there. We use 0.7 mm stainless steel wire with the uh, with a bumper sleeve, what we usually get, or a protective sleeve, and an acrylic bulb is coated with soft liner so that there is no tissue irritation. So the nasal hook is placed in the nostril, diagonally passing the area where you are going to give the dinoplast. You can put a base tape of uh, micropore tape so that there is no much tissue irritation. So this is how it will look like. So lip taping, if there is a cleft involvement of cleft palate also, you can do a lip taping to get the alveolar segment closer, and the pulling force will lift the nasal dome, and you would get a good nasal molding. So the mode of action, what usually happens is the lip taping will get the alveolar segment closure. The nasal stent will pull the nasal cartilage upward, thus creating nasal as well as the alveolar molding. So this is I would not show much case, one or two cases only I would show. This case, it had a semonite band, and the problem was only with the nasal molding. So we have just given the hook, and we have got a good amount of nasal molding with the increase in the cartilage, increase in the columellar height. So this case I put, I know like Dr. Renu would speak more about bilateral cases, but this case I thought is an interesting case because this case had it's a bilateral case, but because of semonite band, the premaxillary segment was connected to the uh, opposing side. That the semonite band was from the palatal segment of the premaxilla connecting to the buccal segment of the other side alveolar. So which has caused the rotation of the premaxilla onto one side. So we have given a mu hook with the modification and a differential lip taping. So what is differential lip taping? We give a tape from the cleft side to the non-cleft side or to the opposing side in bilateral, and you give that, the premaxillary segment rotation cannot be corrected. So what we have done is we have done a lip taping, which is around the columellar, around the premaxillary segment, so that we can rotate the premaxillary segment and correct. So this is how it is been given, and that is how the mu hook is kept. And this is the pre and post treatment result. And the Semonet band was eventually cut and during the surgical procedure. So I would just like to conclude by saying a quote by Leonardo Vinci that simplicity is the ultimate form of sophistication. So by simplifying the nasoalveolar techniques, because by doing that we can also help adopt a technique by many dental healthcare specialists, and also you can also reduce the burden of care for the parents and also the caretakers. So thank you. I would like to thank Indian Society of Cleft Lip and Palate for giving me this opportunity. This is my department, and that's my orthodontist, Dr. Mustafa, and my mentor, Dr. Puneet sir. Thank you everyone. Thank you for the opportunity.
Thank you, Dr. Ashit, for a wonderful presentation. While Dr. Renu will load her presentation, I would request that any of the participants who have questions, please put them in the chat box so that we are able to coordinate and get those queries sorted and a discussion started as soon as all the speakers have actually enlightened us about the topic of what they are going to present today. So I'd now introduce you to Dr. Renu Parmar, who is a rising star in the Indian Cleft Palate Society and a consultant at BMJ Hospital, Bangalore, a very dedicated professional who does brilliant work. So Dr. Renu, please take up your topic. Please unmute yourself. Yeah.
Unmuted. Can you hear me?
Yeah. Go to the presentation. Yeah. Just perfect.
Yeah. Good evening, everybody. So my colleague Dr. Ashit spoke about unilateral clefts and the technique of nasoalveolar molding. So I will quickly go to bilateral clefts, because doing nasoalveolar molding, especially cleft work, for a long time, I'm really intrigued by bilateral clefts, because the variety with these clefts present with is enormous. And from mild to moderate to severe, you can see a variety of presentation of bilateral clefts.
Dr. Renu, can you just go to the presentation, full screen?
Is it okay now?
Yeah, perfect.
Yes. So bilateral clefts can present as mild, moderate, and severe forms. The problem comes when they present with moderate or severe or very severe forms, as you can see in the previous slide. Now, most of the surgeons would agree that their chances of obtaining a finer surgical scar is maximum when the incision heals under minimal tension. They can obtain a finer surgical scar, good nasal tip projection, and more symmetrically precisely defined nasolabial complex. In cases presenting with minor cleft deformity rather than a complex or severe form. Now, in this screen, you can see two pictures. The first picture is a natural presentation of a mild bilateral cleft lip, isolated lip, incomplete. And you can see the severity of presentation is very, very minimal. The second picture is of a patient who has been treated with a complete case of a complete bilateral cleft lip and palate, and the picture is after nasoalveolar molding. So with nasoalveolar molding, definitely the picture is to reduce the main objective is to reduce the severity of the initial cleft presentation. Again, as you can see in this picture, the pre-NAM and the post-NAM basal view of the child, that the severity of the initial cleft deformity is greatly reduced. However, this looks like a very simple statement that, the objective is to reduce the severity of cleft deformity. In my subsequent slides, I will be showing you first the picture of a full-blown severe or moderately severe case of bilateral cleft lip and palate, and then what NAM can help a surgeon and eventually the child to achieve. Most of bilateral cleft lip present with a protruded, severely protruded premaxilla, and most surgeons would agree that their chances of achieving a tension-free closure in such kind of protruded premaxilla is very, very difficult and grave. So this is what with nasoalveolar molding you can achieve. However, this is not ideal. That we wanted a little more of the premaxilla to go back, but sometimes the caretakers are not compliant enough to go for a sufficient duration of nasoalveolar molding. I'll be talking about this in the last part of my presentation, then what happens when you don't do nasoalveolar molding for a sufficient duration of time, or when the child presents late in the OPD for nasoalveolar molding. So you can see that the post-NAM picture, a surgeon would be more happy to see a baby on the operating table in the situation 2 rather than the situation 1. Often severe bilateral clefts present with another problem of rotated premaxilla. Now, the amount of pressure which will be on either side of the lip segments is going to be different, and the tension on the sutures will be more on the side which has a huge gap compared to the other side. Nasoalveolar molding can put this premaxilla into a more physiologic position, not only can derotate and retrude it, but also to a great extent intrude this premaxilla. Now, managing the premaxilla in the vertical plane. Now, this child reported to our clinic when he was 35 days of age, and by this time the premaxilla was quite ossified and hard. But we still went ahead with nasoalveolar molding, though we did not have much of the columnar lengthening. But you see the amount of premaxillary intrusion and the amount of derotation of the premaxilla. Obviously, the picture post-NAM presents an easier case to handle on the operating table when compared to the first one. So these are little steps which molding help you to give, and finally the child can have much better scar, much better nasolabial and complex, and the premaxillary show, which is very crucial to bilateral clefts. Apart from that, a lot of bilateral clefts will have a wide alar base, and the lower lateral cartilages are often flared and flattened. Now, what happens when you do adequate amount of nasoalveolar molding? You see the amount of reduction of the basal width of the alar base width is reduced, and the alveolar cartilages are more or less convex now. Often the lip segments are widely separated. What happens with good amount of nasoalveolar molding? You can see the lip segments are now in much favorable position to obtain a tension-free closure. Most of these patients have a flattened nasal tip, and no matter what you do to the noses, the stigmata of cleft often sits on the nose. So nose becomes a very crucial area to work on in clefts, especially on bilateral clefts. What nasoalveolar molding can do to the nasal tip, it can make this nasal tip more defined, the cartilages more convex. So when we say that the whole idea of doing nasoalveolar molding is to reduce the severity of the initial cleft deformity, then all these little changes add to make the presentation more favorable to have a better result. Severely deficient and absent columella is often seen in bilateral clefts, and what nasoalveolar molding can do is to get a good amount of columnar lengthening. Now, with a sufficient amount of columnar lengthening, of course, the nasolabial complex is defined much more better, and the nose sits on the premaxilla in a vertical position, giving it a definite 3D projection. Often the nasal tip is directly tethered to the prolabium. What nasoalveolar molding can do is actually mold the premaxilla and the nasal cartilages and lengthen the columella in such a form that, again, it helps to get a better nasolabial complex, which is much more defined and sharper. Coming to the appliance design, my colleague Ashit has spoken a lot about it. I will be speaking about only the design which we follow in our unit in BMJ in Bangalore. So like any other unilateral cleft device, we have an acrylic plate And this acrylic plate is a very important part of the device because it is the occlusal stop to the premaxilla. In my last slides, I'll be talking about the premaxillary vertical show. And there, the importance of the acrylic plate is crucial because it acts as a vertical stop to the hanging down premaxilla. So then we have two nasal stents which sit under the medial and the lateral crust of the lateral nasal cartilages, and which molds the cartilage as well as helps in lengthening of the columella. Apart from that, there are two stents which are called retentive stents attached, and to these extraoral traction is applied. The force vectors, now to the occlusal plane, the extraoral traction is applied at approximately an angle of 35 to 40 degrees. Now the angle at which these elastic forces are applied produce two kind of resultant forces. One is an intrusive force, which helps in the intrusion of the premaxilla, and second is the retraction of the premaxilla. And now here, the plate, the occlusal plate, the acrylic plate acts as the vertical stop, not allowing the premaxilla to fall down and extruding. Another component of force is the horizontal taping. This tape also puts retractive force onto the premaxilla to mold the alveolus. So bilateral cleft nose deformity is a complex problem. It requires multiple stages of treatment for a satisfactory outcome. If not attended adequately during the primary surgeries, often these cases tend to aggravate with growth of the nasomaxillary complex, and thus making it a four-dimensional problem. Now, what happens when a child presents in a clinic in a late stage? See, most of the time it is being postulated that nasoalveolar molding is of not much significance after 6 or 7 weeks of birth because there's not much estrogen left in the fetal blood to mold the alar cartilages. However, this we have reserved for those cases who present with a severe deformity, and wherein my surgeon comes and tells that if something can be done to the premaxilla, because we believe that every little bit adds to the overall final result to make it simpler for future surgeries or revisions. So this child presented to the clinic at about almost 2 months of age, and the premaxilla was severely rotated. The alar base was wide, and there was a very little or no columella. Though even after 4 months of good nasoalveolar molding, we could not achieve much of the columellar lengthening. But I'm sure everybody can appreciate the amount of premaxillary straightening and the alar cartilage molding which we have achieved, and the decrease in the alar base width. So if not the columellar lengthening, there are other things which can help a child to achieve a better nasolabial form even if they report late to the clinic. However, there are some drawbacks, of course. Now, the second case reported to us when she was 70 days of age. And in this case also, you see the premaxilla is rotated one of the sides and protruded to a big extent. So this child also underwent almost 4 months of active nasoalveolar molding. At this age, I want to again emphasize that the premaxilla is usually much hard and ossified, that straightening this premaxilla is not easy. So gentle forces on the opposite side is applied so that the premaxilla can be centered, along with horizontal taping so that the premaxilla can go back. And at the same time, we start with simultaneous nasal molding. So you can appreciate the, if not good amount of columellar lengthening, there is sufficient amount of alar cartilage molding. And the premaxilla has gone back, and some amount of intrusion as well, and straightening of this premaxilla. So what I want to say is that even if the child reports late to the clinic, where literature says that you cannot achieve much with nasoalveolar molding, there are some obvious benefits of doing nasoalveolar molding, especially in complex and difficult cases, especially of bilateral complete cleft lip and palate with protruded premaxilla, which is hanging just at the base of the nose and rotated outward. Now, this child is one of the cases which I started really late because the child presented to us in the dental clinic. Now, one of the problems why they present very late is because the awareness is about nasoalveolar molding or reporting early to a cleft clinic is not yet there to the extent which we want. So most of these patients report to the cleft clinic because the doctors or the people around them not have much information about early cleft care. So most of them are told that you have to go to a cleft clinic for a lip surgery at the age of 3 or 4 years, 4 months. And that's why some of these children we see at around 3-4 months of age. So this child reported to the clinic at 3 months. And since her weight gain was very slow, so we did start nasoalveolar molding, though at this age it's not recommended at all. But looking at her premaxillary position and the amount of protraction, the protrusion of the premaxilla, and looking at her nasolabial complex, it was definitely difficult for the surgeon to achieve a tension-free closure or a closure with minimal tension. So anyways, we started with lip tapes and nasoalveolar molding. And you can appreciate that after 5 months of nasoalveolar molding, though she has not come to the ideal position or a good position, but she is still far more better than how she presented in the beginning. And the picture at 4 years shows a fairly okay nasolabial complex, a good amount of columella, if not very satisfactory. The basal view also shows how the premaxilla has been retracted and intruded, and the columella, the presence of a fairly okay columella in this case. Had this child not taken nasoalveolar molding, even for that stipulated time so late in her life, I am sure that her lip and nose would not have been this, and I'm sure she would have required multiple surgeries to address just her nose and lip scar. However, there are issues with late presentation and insufficient amount of nasoalveolar molding, and the problem lies in the vertical plane. That's the premaxillary show. Now, even if her nose and lip scar is fairly okay, this premaxilla is definitely not okay. So, so what I want to convey through this presentation is, I think we have to spread this message that children with cleft lip and palate must attend a cleft clinic early within few days of their birth, so they can avail the maximum benefit of nasoalveolar molding. Because what happens that if adequate amount of nasoalveolar molding is done, then these children would require lesser revisions and lesser GA procedures, thereby enhancing their quality of life and lesser days in hospitals. So now this is how the child is at 4 years of age, and recently I've seen her 3-4 months back. Right now she has not much awareness about her premaxillary show. I'll show you one more patient at the end where this child was about to go to the school and refused to go to the school because of this premaxillary show. So even if we did 4-5 months of nasoalveolar molding, though it was late, we could not address this big issue of this premaxillary show. And as an orthodontist, I feel that I don't think that orthodontically I can manage this premaxilla. It definitely needs an osteotomy. And I totally understand that osteotomy at such early ages like 4, 5, 6, 7 years are too traumatic to the maxillary growth. However, I would give much more preference to the psychological development of my child rather than the facial development, because I think I can handle it later when the child comes to the clinic at 14, 15 years of age. So what is happening, it's not just her aesthetic which is getting ruined because of the premaxillary show, but look at what is happening to the function. She has such a traumatic bite that she has a lot of gingival recession and a lot of attrition of her deciduous teeth. And temporarily, right now, we have given her a lower bite block to avoid this trauma. But this definitely is a temporary solution, and the permanent solution is a premaxillary osteotomy, knowing fully that it can hamper the maxilla's anterior-posterior growth. Now, nasal hooks, though I'm not a very big fan of nasal hooks, it is reserved in our clinic to cases who present after 6 or 7 weeks of birth, and cases with isolated lip with or without alveolus, or patients who are unable to follow with the bi-weekly protocol of nasoalveolar molding. So what happens, why I'm not a big fan of nasoalveolar molding, I'll just put one presentation here with nasal hooks. Now, nasal hooks, though, is a very promising solution in some cases, like I've told, in isolated lip with or without alveolus, or it's a mild presentation of a bilateral cleft lip and palate, but not too much protruded premaxilla. Now, this child presented to us with a complete bilateral cleft lip and palate, and we did nasoalveolar, rather than doing the regular nasoalveolar molding technique, we did nasal tapes. Now, what happens with lip tapes and nasal hooks, is the premaxillary show is not controlled. Now, as I told in the beginning slide, that the occlusal plate act as a vertical stop. Now, that stop is not there when you're doing nasal hooks, because there is no acrylic plate or no elastic traction to push this premaxilla upward and backward. So you see this premaxillary show, and this child too needs a premaxillary osteotomy to take care of this problem. So even if the nose and lip is fine, the premaxilla is definitely not okay. These two cases are of no nasoalveolar molding, no nasal hooks, and no lip tapings. Now, they have similar problems like that of late presentation of patients which present late with minimal nasoalveolar molding, or patients with nasal hook and with lip tapings. Now, this is the case wherein this patient's father walked into a clinic and requested us if we can do something about this premaxilla, because this child was 6 years and was refusing to attend the school because of obvious bullying. Now, knowing fully well that this can lead to a mid-phase deficiency or difficulty of growth of maxilla in the precipitant, we went ahead with premaxillary osteotomy, because what we want is the child to go back to the school, and if any kind of maxillary growth retardation or hindrance is there, that we would plan to take care later. But what I want to tell here, that every step to manage a moderate to severe case of bilateral cleft lip and palate child is important. No matter what age they represent, if it's severe, we must do either lip taping, nasal hooks, or what, if possible, nasoalveolar molding. Another word of caution which I want to tell is, when you start nasoalveolar molding late, those patients, there is always a very high chance percentage that they might not accept the nasoalveolar molding device. And obviously, you will have to step down to lip tapes and nasal hooks. However, I guess it's worth the try. So compared to the presentation that they come with severe presentation of premaxilla, deficient columella, alar cartilages, it's worth a try that one should try nasoalveolar molding even in patients presenting at 8 weeks or 9 weeks or even 10 weeks of life. So every step counts to give a child a pleasant nasolabial complex, a confident smile, and a functionally good occlusion. With that, I thank everybody here for your patient listening. Thank you so much.
Wonderful presentation, Dr. Renu. While we continue further, there are some questions which have come up in the chat box, and let us just deal with a few of them as we move along. The question about which has been asked is about the timing of PNAM. You mentioned that in a lot of cases at an older age also, you found good results. So can you just, the participants want to know that is timing that critical or is it not?
Timing is very critical to nasoalveolar molding. So the ideal right time, if you ask me, I want to see my children within first 1 week of birth. What I wanted to emphasize with the latest slides is that, some patients of bilateral cleft lip and palate present with a severe form. There it's worth a try that you try doing few months of nasoalveolar molding. If not the premaxillary position, maybe the premaxilla would come 3 to 4 millimeters back, so that it will benefit your surgeon to take the advantage of lesser tension, at least if not tension free, lesser tension onto the sutures. Because we all know that if there's a lot of tension, it will scar more. And if it scar more, there's need of a revision. And if there's need of revision, there is a GA. And the child during his school going ages is going to be in your OT more than in school. So I would say the ideal time is within 1 week, 10 days, ideal age.
Right.
However, you must try doing nasoalveolar molding or lip tapes and nasal hooks, even if they're present later and if they're ready to cooperate with you.
Perfect. So another similar question on similar lines, that it's an 8-week-old baby and it's not compliant wearing your appliance. So what would be your strategy in handling such a case, especially when they also have a feeding issue?
I'll just share my experience with you that, most of the time if a baby is 8 weeks plus, it is very difficult to make them wear the plate. However, there are chances they might wear it. The duration they take, the time they take to adjust to a plate can be anywhere between 3 to 5 days. If they do not adjust to that, then you will have to give up on NAM. You can try nasal hooks with lip tapes, or maybe just lip tapes. If they don't cooperate with that also, nothing then.
Right. Dr. Ashit, are you with us?
Yes, sir.
There are some questions for you. That
Yes, sir.
what about warmer bending? Many times you instead of doing molding, you apply pressure and there is bone bending.
Yes,
So
sir.
what are the problems anticipated in the future for such a child, and how do you counter it while you do NAM?
Yes, sir. I feel like if there is more of a hemorrhoid bending, so if there is, that itself says that the force which you are exerting, usually in a bilateral cleft, is more. So there are chances of a hemorrhoid fracture, hemorrhoid bone fracture, if the excessive force is there. And if there is any hemorrhoid bending, just a bending, then there are chance of relapse. It would be much higher compared to a normal case, because this bending would, once the appliance is removed, it might tend to go back to its original position.
Right.
Yes.
Something very basic but very, very important is being asked, that how do how can you simplify impressions, and what material do you like to use for making impressions for cleft babies?
Sir, I personally use only elastomeric impression only. I don't use alginate or any other impression. I have given, if you see my presentation also, I have given few shortcuts. That's all. Like instead, initially when I started, I used to use impression compound for taking primary impression, which now I don't use. I use wax only for taking the primary impression. On that wax only, I do my primary cast, over which I make special tray to take the secondary impression. But once you have enough number of cases, these trays can be used for different patients. You can disinfect and use it for different.
Perfect. Another question is that how do you while doing NAM, how do you know that your direction of forces is correct? Because many times you end up in a mega nostril.
Yes, sir. So this was always a question for me also. So what I usually used to do earlier is, I used to take a ligature wire and then measure the nostril of the opposing side. And because initially when I started doing nasoalveolar molding, my first two cases, my surgeon was not very happy. He said, you have overdone them. So, and there was and the case we have finished, it looked, nose looked very good. But when you measure from right to the left side, then molded side was much bigger. So that's why now if you see my cases, whatever I have presented today, uh, I have not overdone. I have done just enough, and then the surgeons would do a good job to get the
Right.
nose shape into good shape.
So one question is that how many layers of wax do you use?
One single layer, sir.
Single layer.
One layer. Yes, sir.
And one more question is that how does your NAM appliance stay? Do you prefer to use a denture adhesive?
No, sir. It's a very passive appliance. In the unilateral one which you are using,
Yeah.
so I don't use any denture adhesive, sir. For bilateral, what I use, the bilateral what I showed in 3D, we use a little bit of undercut where we use the soft liners to get a better retention. In unilateral, it is a passive appliance, so we don't use any adhesive.
Thank you, Dr. Ashit. Well,
Thanks.
it's my proud privilege to introduce the next speaker, who is none other than Dr. Maria Constanza Meazzini. She is the scientific director and the orthodontic consultant for craniofacial anomalies in Smile House, Cleft Lip and Palate Center in San Paolo e Carlo Hospital in Milano, and the Department of Maxillofacial Surgery, San Gerardo Hospital, Monza. She is an adjunct professor in craniofacial anomalies for residencies in maxillofacial surgery and orthodontics in the University of Milano, the president of the European Cleft Lip and Palate and Craniofacial Association, and a representation for European Reference Network. She acquired a specialty in orthodontics and a master in medical science from 1991 to 95 from the Harvard University, and completed a craniofacial and surgical orthodontic fellowship from University of Illinois in Chicago from 1995 to 96. Well, it's a real proud privilege to have her on board, and she has been, a very close friend of the Indian Cleft Lip and Palate Society. She has visited us often and has guided us in a big way. In fact, I'll just share a small moment with you that I messaged her that, ma'am, one of my postgraduates wants to do something on Ultramic. And there she sent a picture. She said, don't worry, any help required, I'm there. So this is the woman, the lady who is always there to help for patients with cleft lip and palate and craniofacial anomalies. We are really proud, and I present to her today's podium to educate members of the Indian Cleft Palate Society. Thank you, ma'am, for accepting our invitation. You have to unmute yourself. Unmute yourself. Yeah.
You're right. Sorry, forgot to unmute. Thank you so much. It's an honor to be here again. Do you want me to share the screen?
Yes, ma'am. Yeah.
Okay. It's coming. Okay. There it is. My computer is slightly slow, but it should come in presentation in a minute. There. So it's an honor for me to be linked with your society, which, as you said, I adore. And actually, I thank you, Professor Batra, also for asking me to talk about a topic that I never actually, I'm never invited to talk about. I always talk about NAM or alveolar, but really never about mixed dentition, and that's a very important time in a kid's life. And just to emphasize how much I love India.
Chalo, aaja.
There's a voice of somebody. How much I love India. These are some pictures from the InnoCleftCon in 2015, and you will probably recognize many of your friends there. And these are some pictures from the 2017 International Cleft Congress. And I think you recognize the guy here in the middle. And what I want you to look at is this beautiful dress. And this beautiful dress was given to me by that young, wonderful doctor that you just heard talking about, NAM, Renu. And I adore this dress. It's a shame I don't have it today. But anyways, I'll go to the talk. And the first question that the surgeon, but especially the families, ask an orthodontist is, well, when should orthodontic treatment start? And I started my residency in 1991, so it's almost 30 years ago. So my teachers were really good, great orthodontists and cleft orthodontists, but that were trained in the 70s. And they would tell me that if you started early and you expanded early or you protracted the maxilla early, you would get better function and therefore better form. So you would improve the prognosis in terms of growth of these children. But the literature since has shown, starting from Ross and the Eurocleft, and we've done a piece of our own science looking at our cases retrospectively. And what we've seen is that a child who's just as severe at 5, the one that gets a lot of early orthodontics compared to the one that gets very little, eventually have the same amount of growth. So definitely starting early, like in deciduous dentition, doesn't really help prognosis. And I would divide this sort of short talk into the transversal discrepancies and then sagittal discrepancies. So if you have a transversal discrepancy, which is almost in all cleft patients, when should you take care of it? And although you should never say always or never say never, in general, I would try to avoid at all costs deciduous dentition. Why? Because on one side, it's very unstable. You have to keep it somehow, either rigidly, and that doesn't allow for good hygiene, or with a removable retention, and that's also a problem because then the kid can't put the tongue in the right position. And if you have a case like this one, for example, which was sent to me to do an expansion because it had a crossbite on the right side, what I would have done is opening a fistula or a neuronasal passage. And in a child who had a normal life with no problems, no food in her nose, no problems with speech, I would have done a disaster because she was not ready for bone grafting. And so, as you shall see later, we had to wait 3 years till it was a time to do surgery, and then we could do orthodontics. So when should we start? Well, it sounds silly, it almost sounds too obvious, but really when it's needed, you shouldn't start too early compared to when you really have the necessity to do it. So if you have a child and you'll see that, who's had already a surgery by which the alveolar bone is ossified, then oftentimes you need some expansion to give space for the incisors or to give space for the canines. If you're dealing with the protocol, as you shall see, that needs bone grafting, then usually before the bone grafting, you need to expand, not always, but very often. And then there are two instances that I'm very passionate about, and that's when more seldom a child has an obstructive sleep apnea, and very seldom in these children, though, you have hearing loss. And an orthodontist can do so much for a child in mixed dentition with hearing loss. Then if you have articulatory difficulties, I don't know if there are any speech pathologists in the group that are listening, but what I do is basically listen to what my speech therapist says. Dr. Ezzonico is like a genius of speech therapy. When she tells me she needs it, I just obey. So no brains, I switch my brain off and I do what she tells me to do. So let's go to my favorite topic at this moment, which is recurrent otitis. If you have a child with severe recurrent otitis with no pain, but just enough so that the eardrum doesn't vibrate enough, and so the child really doesn't hear as well as he should, then an expander, and we've seen it also in the non-cleft literature, can give a stretching of the dilator muscles so that you can open the pharyngeal orifice to the Eustachian tubes, and so the drainage of the middle ear will be much better, and little by little the child will hear better, as you shall see. We started a few years ago with Professor Felizati, who's the head of the ENT department, and we were both really surprised and happy that after 1 or 2 expansions, we could go from a hearing problem, as you see on the left side, on both ears, and a tympanometry type B. Just for those of you who don't know, a type B is the worst. So it means the eardrum is really rigid, it doesn't vibrate. A C is in between, and A is a perfect eardrum. I don't know why ENTs have to do that. Why couldn't they do ABC? They do ACB. But when you see the others, you'll know. And look at after the treatment, the orthodontic treatment, the child hears perfectly. This is one example. This child got a first expansion and then a second fan expansion using the permanent teeth. But if you see the amount of hearing loss this child had to start with, and the flat tympanogram, that means there's no elasticity in the eardrums. After the first expansion, we had a net improvement in the hearing, and what you see is that there is elasticity. So when you put negative pressure, the eardrums lift up. So we had already improved completely the elasticity of the eardrums and improved it to a great extent the hearing problem. And then after the second expansion, the hearing problem was not there any longer and eardrums were still perfect. And the reason, as we said, was that you get some stretching of the tensile veli palatine muscle, and at the same time you improve nasal breathing and you reduce nasopharyngeal inflammation, so the orifices are nice and clean and the ear can function normally. And definitely RPE, with or without, as we shall see, a a face mask can be a much less invasive technique with a greater effectiveness compared to ventilation tubes. I had the honor of publishing the initial, so sort of the very initial results of this study. Now that we're doing a second expansion or attraction, we're getting a higher amount of correction. And we added, I could add also some results of the improvement with orthodontics of the obstructive sleep apnea syndrome patients that I was mentioning before. And we know also from the orthodontic literature that expansion can improve the airway. We know that surgery, advancing the maxilla or the midface, improves the airway and eliminates obstructive sleep apnea syndrome. And we could do the same with a lot of other syndromes such as chondroplasia or trichocolins, but also with our cleft patients, a little less commonly, but especially with cleft patients who have a pharyngeal flap, with great results, going from indices which are around 20 to indices which are around 1. And the reason why you can do that is simple fluidodynamics. If you look at one choana, if when you do the expansion, the choana goes from 2 millimeters to 3, that means you've gotten 1 millimeter on either side extra. We already know that because of this law, which is called Poiseuille's law, because it's the fourth power of the radius that decreases the resistance, we have decreased the resistance so much by just 1 millimeter that we have an increase in airway, in airflow volume of 5 times. And that's the reason why it works so well. So aside from these two aspects that fascinate me so much, of course, there is all the orthodontic treatment that has always been done. If it's a patient needing bone grafting, often in preparation with a bone grafting, this is a child that I treated very many years ago. And if you see the lesser segment is collapsed against a major segment, so you need to do some expansion. Unfortunately, all the baby teeth had been extracted by a dentist years before, or at least a year before. So there had been some mesial movement of the permanent teeth, and we had to use a quad helix. I prefer using expanders in general, but we needed to use permanent teeth to expand the lesser segment. Once the lesser segment was expanded, we did the surgeon, and it was Dr. Mazzoleni from San Gerardo who did the bone grafting. And as you see here, then the tooth, the canine erupted in the area where the graft was done. In the meantime, this is a follow-up of the orthodontic treatment. 2 premolars were extracted in the lower arch and 1 on the right side, so that then we could go from this occlusion to this stable socked-in occlusion, which allows you to be sure that it will be stable in the long term. And this is a patient 12 years post-treatment, and I was lucky enough to go to her wedding, and she's a successful skater. Another example that I like showing, I'll just show you sort of spot examples that might tell you something. Another important aspect when you have a child who is waiting for bone grafting is not to touch the front teeth before the bone grafting, unless it's needed, unless the surgeon asks you. So it's usually in the opposite direction of the cleft. If you look at this child, for example, if we had, just to make her happy, straightened this central incisor, we would have had a big problem with the position of the root into the cleft. So what you want to do is do some expansion, not the whole thing, just what the surgeon needs. Then the surgeon then does the bone grafting, and then you keep on expanding after the bone grafting. I usually start like 2 months after the bone grafting, and then the canine has erupted into the graft. And this is also one of the few cases where I have put and dragged the canine in the position of the canine. I usually prefer closing the space, as you shall see, of the missing lateral incisor with the canine. But here we put the canine in a nice class 1 occlusion, and there was, after bone grafting, still a pretty good amount of bone. But unfortunately, what happens, especially if the patient does not accept a sort of tertiary bone graft for the implant, what you see is a little bit of defects. And so aesthetically, it's never as nice as what you can obtain with the mesialization of your canine, especially in the very long term. Although what you want for your patient is not necessarily what the patient wants. And this patient has still a very nice smile, even if she has an implant. And this is her very good looking boyfriend. In some instances, especially when you have very good growth, this is a case that I'm showing because I just like it. They were twins, adopted twins. One had no cleft and the other one had a cleft, both with typical profiles of Southern American children. So with a protruding maxilla and a slightly protruded mandible. So in both cases, we decided to do extractions. In the non-cleft child, we extracted 2 premolars. In the cleft child, we extracted only 1 premolar. So we did the expansion. Then the bone grafting was done. The canine erupted into the area where the lateral incisor would have been. And then we did just an alignment so that we could have nice socked in canine on one side and premolar on the other side. And both siblings had exactly the same amount of months of treatment. This is a girl that you've seen before. So we should not have touched her at 6, but by 9, she was ready for bone grafting. In her case, bone grafting was done before expansion because the surgeon didn't need it. So after bone grafting, we did the expansion immediately after bone grafting. We did the expansion, and at the same time, using as anchorage the roots, the bands on the baby teeth, we did a rotation of the central incisor, which was completely derotated. So in a matter of 9 months, it was actually 11 months, we could derotate this incisor, put it in the correct position, just with 1 wire, the TMA wire that you activate little by little, and then the 2 central incisors were splinted. Everything was taken out. The child was left alone till permanent dentition came in, and so the lateral incisor, although a little, came out, and there was a transposition between premolar and canine. I'm not heroic, I just leave it. And this is after the alignment with the canine in the place of the premolar. The premolar we just left in where it wanted to be, and the alignment was nice and socked in with a stable occlusion. If you have another type of surgical protocol, which has, like in Milano, a late gingival vuloplasty, that means it's like a periosteoplasty, but instead of doing it at birth, it's done at about 2 years together with the closure of the hard palate in order to get less hindrance of the growth and a higher amount of ossification. And we've published many papers about the ossification. We know that we have about 3% of non-ossification. Most of the patients don't need any secondary bone grafting. So in these patients in general, you can just treat them as if they were normal children. So what you do is, in a child like this, you put your expander, you give the space for the rotation of the central incisors, you derotate those teeth and you block them. Take everything away, leave them alone, and then take it back in permanent dentition. This is a child with a good growth prognosis and therefore with a good follow-up then in the long term. Another child, same thing, expansion. He had an expansion done by another orthodontist to start with, so I had to just keep the same expander and add some acrylic because sometimes the larger segment tends to expand more than the lesser segment. But after the expansion, everything was taken out, and then impermanent dentition and alignment was done. And as in the case before, you have a socked-in inclusion, which is stable in the long term. And he's a very successful soccer player. They send me pictures, and I like putting them in because it makes it all more real. They are patients, but they are friends and almost children for all of us. This is a case that I like showing because it's typical of children who've had periosteal gingival vuloplasty. He had been treated by another orthodontist with an expander, but the lesser segment had not expanded at all. What I do when the lesser segment is really rigid is put an expander with a lingual shield on the larger segment so that we can get an overexpansion on the lesser segment. This child needed a second expansion to give me more bone for these two teeth, which didn't have enough bone. So what we did was expand with the fan expander, again with the shield, in order to have enough space and bone to align these teeth. So what we had was this occlusion to start with, after one expansion, after the second expansion with the shield, and then after the alignment. So we went from this type of occlusion to a good socked in class 1 occlusion bilaterally. This is the last unilateral case of gingivoviloplasty I'll show, but it's interesting because of the overexpansion that I could obtain after the first phase. The central incisor was in trauma, so we had to move it in the correct position. And while doing so, we created a lot of space, but we wanted a lot of space in the area of the missing lateral incisor, because what we want, and it's not evidence, I mean, I don't have proof that it works all the time, but it works quite often. We want the canine to erupt in the area where the lateral incisor would have been if it had existed. And that's exactly what happened in this case. If you see the CT scan that was taken to check for bone ossification during the study, you see also that the canine has migrated almost in the spot where the lateral incisor will be, and all the other teeth have migrated mesially spontaneously. So what we did was just simple permanent dentition orthodontics, which was in the long term extremely stable, with at 7 years of distance a good socked in occlusion, only a skin problem. I'll just show you briefly a bilateral case with the same surgical protocol. In bilaterals, you're not that sure about ossification in general. So once you've done your first phase that you see here in deciduous dentition, which I'll take again here in deciduous dentition, we do one expansion with a fan expander. After the fan expansion, we notice this sort of notching here. So we took a CT scan. At the time, it wasn't that common to take CT scans. And we've seen that on this side, there wasn't as much bone as on the right side. The nasal notching is the same, but the alveolar notching is not that nice. So what we did was bring forward one of the lateral incisor. It was even the smaller one, so that it would bring some bone with it. And so we could finish up, and then we extracted it so that then the other lateral incisor, the supernumerary one, could come out in the palatal mucosa, but then by bringing it into the arch, we could bring bone with it. And so we finished up with an expansion and then an alignment, bringing bone with it, as you shall see here, with a good amount of bone on both lateral incisors. And so bilaterals have a little higher burden of care because there were 2 phases of fan expansion and then about a year in total of 2 years in total of orthodontic treatment. As I told you, I prefer to start thinking about closing the space in deciduous dentition, in mixed dentition. So also this child had one expansion done by another orthodontist. That baby tooth up there was then taken out. But as you've seen, the canine has erupted almost in the site of the missing lateral incisor, and everything else has migrated spontaneously. So all we needed was regular permanent dentition orthodontics, and we could bring this canine forward and fill in the thickness of this bone in order to obtain this result with a good occlusion and good growth in the long term. He was to start with, and a good follow-up at 23 years of age, still a very nice socked-in occlusion. And who says that a midline which is slightly off to one side is a problem? I find it more or less, if the smile is nice, as good as having a centered midline. Although I think Tom Cruise then had it fixed, but I thought he had a nice smile when he was young. Another important aspect when you are in mixed dentition is canine impaction. You should always check for that. It's more common in cleft children than in non-cleft children. So when you have a child like this one, and you've taken your panoramic X-ray and you see that there is a risk of impaction or the canine is already mesially positioned, you take a CT scan and you see that the canine is actually not only mesial behind the central incisor, but it's also resorbed a little bit of the lateral incisor. At that point, what you do is overexpand with a fan expander in this case. Once you've overexpanded, you extract the lateral and the first baby tooth, first baby molar, and the canine deciduous tooth, and then you bring into the arch your canine, trying to keep the roots initially as back as possible, so you have a nice thickness of the bone, so that she can finish with a nice thickness of the bone in front of the canine that has been brought into the arch. Now, let's briefly, because I'm not sure if I'm a little bit long, briefly talk about protraction, so the sagittal discrepancy. And we know that at 10 years, you already notice, so still in deciduous dentition, a problem with your sagittal growth of the maxilla, but we also know that at 11, 13 years, it gets a lot worse and it becomes surgical case at 18, 20 years of age. What we know from what we said before is that if we treat the child early on, though, it tends to come back, and you'll see that. So when should we treat a maxillary hyperplasia? What we know is that in deciduous dentition, we can use a face mask, and it's very efficient at 8, 9 years of age, not as much later on. And it has advantages, but also big limits. And the limitations are, as I just said, it's efficient at 6 to 8 years of age, but less at 10 to 11 years. It doesn't protract the maxilla very much. The maxilla comes forward like 2 millimeters, and that's not very much in the long term. And this is a picture that was taken in Chennai in 2017, and it was interesting because in the same session, we were talking together with Dr. Tinlund, and I mentioned him showing his graph. And while he was saying that it was important to do it early, because then you would have a better function, which is typically 70s as an approach, I was showing his graphs and showing that in a matter of a year and a half, too, you would lose completely the SNA and lose completely the A and B that you had obtained with the protraction in mixed dentition. And this is an example that was treated at the Smile House years ago. There was a face mask position at 5 years of age, then at 10 years of age, again, but at 15, he was a class 3, and at 18 years of age, he needed an osteotomy. This is another girl that was treated before I came at the Smile House with a delaire at 6 years of age. At 7, she was really pretty, but at 11 years of age, she was a class 3 full cusp. And at 16 years of age, she was ready for a Lefort 1 osteotomy. So when do I do protraction in mixed dentition? Well, only in special cases and with special indications, because I know that otherwise it will go back. So if there's trauma, that's a big indication for orthodontics, because we know that you have root resorption. So if you have a child like this who has trauma on his incisors, you can tell the family that we can either do a splint or protract the maxilla, because she wanted some aesthetics and she was almost 8 years old. We did a protraction, but we told the family that the improvement that we got, which is definitely there, will only be there for a couple of years, maximum 3 years. And that's what happened. And that's when she started the ultramic technique in full permanent dentition. Another exception is as I said before, recurrent otitis. Very often with a face mask, you get brilliant results in terms of otitis. And this is one child where we did a protraction of the maxilla. And right after the protraction, what we had was skeletally an improvement that we know we will lose sooner or later. But from the hearing point of view, we know we will not lose it. And the conductive hearing loss that he had was completely resolved right after the protraction and also in the long term. Obstructive sleep apnea is very much helped, and we've published some papers about it. This is a child who had also a cleft palate and a mild Treacher-Collins, that after protraction and expansion didn't need any further surgeries and had a completely resolved AHI. If you have no other reason, I have talked about it when I was in Chennai and when I was in Goa, I would do really nothing and I would wait and use the ultramic technique that Eric Leo has taught us and that I have only modified to adjust to Caucasian features. So I don't do extractions in the lower and in the upper always. I put TADs instead of doing extractions, but the principle of mobilizing all the maxillary sutures is the same and the timing is the same. So as late as possible, possibly at B3 stage. So when the child is about 13, 14 years of age, then you can start protracting your maxilla. And this is the publication in the long term of the cleft patients. And we've actually, with an almost 6 millimeter advancement, which is really very much. And we've also published, and it's coming out very soon, in the AGDO, the non-cleft children with an advancement, which is slightly less, but still allows you to avoid osteotomies with a long term of almost 20 years of age. This is a cleft child that you've seen before, and thanks to Dr. Mazzoleni, instead of telling me, well, leave her alone, I'll do surgery when she's older, I did a preparation at the time with, I didn't use TADs at the time, so what I did was decompensate the lower arch and open and close a few times till we could get to this stage with a mobile maxilla and an advancement, which is very similar to a surgical advancement with a good result in the short term. But what's more important is that at 25 years of age, she's still very stable and socked in. I'll just show you a male subject, which is a lot more difficult. At 10, he had a retrusion, but if we had done a Delaire mask or a face mask treatment here, we would have definitely had to do it again at 13. So what we did was wait till he was 13, already compensating. You see the lower arch crowding and the lower teeth compensating. And that's when we started. You see the screws in the upper arch to allow for skeletal movement of the upper arch, then an extraction of the lateral incisor to center the midlines, and then a socked-in occlusion, which is maintained until at 21 years of age, he got a rhinoplasty from Dr. Otilitano from the Smile House. And I've seen him recently, about a year ago, and he was 25 years of age with a nice socked-in occlusion. I've just added a couple of cases while Renu was talking, because she said you can't do it orthodontically. You can and you have to. Don't let your surgeon touch a case like this. This is a simplified. I've published a more complex way, but this is a simplified way of intruding the premaxilla. You just put, and I can talk to you about it and send you the pictures. You intrude with wires. It takes 1 year. You intrude the whole premaxilla, and then your surgeon can do. In this case, he's done. Dr. Otilitano has done bilaterally cleft palate closure and the gingival alveoloplasty. But for example, this is a patient that was sent to me a year ago from Romania. So just to tell you how little you have to see the patient, because I've seen her only every 4 months, and then there's been the COVID stop. So this is a last case that I'm showing you, and I've put the same appliances that I've shown you in the other case, so acrylic appliances and an expander, and check the patient every 4 months, and then with the COVID stop 6 months after. And that's what she looked like when I took everything away 6 months when she came back after the COVID stop. And this is what she looked like before the intrusion. And this is 1 year after her occlusion, before, so she still has baby teeth there. And her smile in the front after the intrusion without any surgery. And because I have follow-ups of my previous technique with patients that are now 25, 26 years of age with good growth, I really wouldn't suggest to do surgery in these children, because the orthodontist can do it and lesser the amount of surgical burden of care and successive burden of care. So I thank you very much for your attention. And I hope, as Dr. Krishnamurti was saying before, to have a lot of Indian people in 2000, a lot of Indian doctors in 2024 in Milano for the European Cleft Palate Craniofacial Association. Thank you very much.
Thank you, Maria. That was amazing. Your work, is ultimate and amazing. And in fact, there are a few questions which have already come up. The first question is that many people appreciated that how you close spaces using the canine. That is, there is no artificial tooth required, and in a situation where there are affordability is an issue for a dental implant, when you have your own set of dentition, it's a very good solution. But one question is that once you bring the canine in place of a lateral incisor, the premolar is in place of the canine. So how do you manage your canine guidance? Because there's a premolar palatal cusp also, which is going to hinder the lateral excursions.
Yes, I generally then little by little grind the cusp, the palatal cusp, but usually it's never canine guidance, it's group guidance on that side. I actually have missing lateral incisors myself with canines here, and so I have group guidance bilaterally. Okay. So I always show my face to my patients, say, I'm not the prettiest woman in the planet, but I have a nice husband and 3 kids, so he can put his canines in the right spot, and instead of the laterals, and survive nicely and have no fake teeth. So I not because it's my personal experience, but because really I've seen so many cases after 10 years or 15 years with the implant, where the implant shows a little bit, the bone goes away, and then aesthetically it's not pleasing. Even when the patients don't have a gingival show, it's really often enough. And then if hygiene is not good, you have big time problems. So if you have their own tooth, I am so much happier.
The next question is that somebody wants to know that, the protruded premaxilla, which is descended down, what appliance do you prefer?
The one that I just
your second last case. It says.
Yes, because it wasn't part of, that's done usually in deciduous dentition. I published a paper in 2009, I think, and I used to use a rigid intrusion device that I think I've shown in Chennai when you organized the session. But it's a lot more complicated even for the orthodontist, and this sort of modification that I've done is so simple. So you have an expander like a McNamara expander, and then you put an acrylic topping of the baby teeth because you don't want them to mobilize during the intrusion. And then you just change. Initially, I put a TMA wire activated, and then I go for night-eye wires, and it's a soft, subtle intrusion. In a matter of 12 months, you're done. You take everything off. The child has a nice smile, and you've done no surgery. So that last, we sent it for publication now, so I'm not sure when it's going to come out. But it's so simple, and especially for a country like India, where people can't travel that much. That Romanian girls that I've shown, little baby, I don't know how to call her, that I've just shown, I've seen her 4 months, and then there was the COVID stop, so she couldn't come to Italy. And so I let her alone till a couple of months ago when she could come, and I took everything away. So she came 3 times total. And that was really a low burden of care, no surgery, and she was enthusiastic.
Okay. The next question is that you expand before or after the bone graft, and are there some principles you want to follow? The next question linked with this is that, can immediate expansion after the graft hinder the healing of the bone which has been grafted?
Okay. Whether I expand before or after is a decision that we take with the surgeon. So if the segments are already aligned properly, of course, there's no need for the orthodontist to expand. Sometimes you do over expansions and you make it more difficult for the surgeon. So that's a decision that we take together. I would say that at least 60 to 65% of the patients though need expansion because the lesser segment is usually collapsed. So in general, I do the expansion before, not completely. So I just put it in a position that the surgeon finds easy, let him work, then put the expander back in, wait 2 months, and then expand the whole way. If it's done immediately, some authors say that after, although there are authors, for example, a couple American groups like South Carolina, North Carolina, they tend to do expansion 2 weeks after. But because there is some literature that says that you might have a problem with the grafted bone, then we do sort of a compromise and wait at least 1.5 months to 2 to do the expansion. So, and then in that case, there are studies that show that you even help the bone grafting. So we just wait for a first remodeling of the bone and then we expand.
Perfect. The next question is that, with Ultramic, you show brilliant results of about 5 to 6 millimeters of protraction. But does that ever lead to a velopharyngeal insufficiency? Because it's almost like a surgery.
Yeah, that's a great question. And we are actually, we have studied 30 patients now with Dr. Rezzonico, the wonderful speech pathologist that I was talking about. And there is, in many instances, during the first month of protraction, when you get the maximum movement, there is a temporary velopharyngeal insufficiency, not velopharyngeal, but nasality in the speech. The reason why it seems, and that's Dr. Rezzonico's interpretation, the reason why it always comes back is that you're not cutting any soft tissue there. So you're coming forward and the soft tissues are, the annulus, posterior annulus comes forward altogether. So you have a moment where the soft palate has a hard time touching, but then because you're pulling everything together and you're not doing any osteotomies, any cuts in the soft tissues, then what you had before is what you keep on having. So if they were borderline to start with, they'll still be borderline. But if they were not borderline, there will be perfect speech with no nasality at the completion. And the reason we believe is that there is no surgery.
The other question is that, when, what is, it's 2 parts. The first part is that what do you consider is an ideal timing for maxillary protraction? The second part of the question is that, once you've achieved a maximum protraction, skeletal protraction, and still the incisors are in an edge-to-edge bite, would you like to start orthodontics immediately to do some, dental movement with elastics, or would you like to wait and do orthodontics later on?
Okay, when I would start as late as possible. So what I look at are especially the vertebrae, and it should be 3rd stage of vertebral maturation. And if there are other parameters that I use, like if the girl has had menarche about 6 months before, that's already a good timing to start. For the boys, when they start growing a lot faster and changing their shoes quite a lot faster, that's a good timing. But usually vertebrae help me a lot. What I always do now is take also a CT scan, especially if I'm a little bit too late, because I've had 2 cases where both had bone grafting. So I think it's probably more common after bone grafting, where there was either bridging ossification in the palate or early closure of the mid-palatal suture, and I couldn't do the expansion. But in every other case, what I do, once I've opened and closed and opened and closed, and I feel that the maxilla is mobile, I try to go forward, and unless the mandible is really, really long, I keep on going till the maxilla has overrun so I never leave the child in an edge to edge. I always overcorrect. And if you don't overcorrect, like if it's a boy, the only times that I've left them in a good occlusion, it's when at 21 they were edge to edge. So especially in bilaterals and in males, I want to have at least, so the advancement is more than 6 millimeters in those cases. The average amount is 6 millimeters, but Eric has shown 11 millimeters. I don't think I've ever gotten to 11 millimeters, but probably 9 to 10 quite a lot of times. So there are advancements, there are sometimes closer to what you can get with osteotomies or distraction devices. But it's a lot of work for the patient. And to get that, I put TADs in the lower arch and TADs in the upper arch. And if the springs break, I have to substitute them with elastics that the child has to wear always, even while eating. So it's a lot of work. So you have to have a patient who's very, very collaborating and really wants to get the job done. Otherwise, you might as well wait for surgery.
The other question is that how effective is the protocol of expansion? You expand and remove the appliance just before the bone graft and then continuing with orthodontics. How effective do you think is this protocol?
So what I do is expand, do the bone grafting, and then the expander, the same expander, I put it back on.
How soon?
And keep on expanding till I've gotten the width, the over expansion that I want. And then depending on how early, because in some cases, the bone grafting is done so early that you don't have enough permanent dentition to do your orthodontics. So what I do is just take everything away, let the child alone for a year, and then, or year and a half, it depends, sometimes 2 years, and then do the permanent dentition orthodontics. In some other cases, it's all a continuum with non-stop. So if you're already almost in permanent dentition, then I would do non-stop, but it depends on the child and how far it is in the dentition.
Thank you, Dr. Maria, for just enlightening everybody here. Everybody is really excited to be in touch with you. And while we continue further, because other questions are coming around, I request Dr. Pallavi Daigavne. She is one of the people who is always working hard. She just finished her PhD in cleft work, and her career started with NAM, and I was seen on the stage talking on NAM. So this time I motivated her that she should talk, since she's done a lot of surgical cases, to talk about orthodontic surgery in cleft patients. Dr. Pallavi.
Whose mic is on, can you please switch off your mic?
Hello, am I audible?
Yes.
Yes.
Pallavi, you'll have to unmute yourself.
Am I audible?
Yeah, you are audible.
Okay. So good evening once again, everyone. I'm from Sharat Pawar Dental College and Hospital, Savangi Meghe, Wardha. And a few glimpses of the activities done in the Smile Train ortho department. 1 second, just give me one.
Just below the screen, there must be an arrow on the lower left side. Just click on that arrow.
Just go to the next slide.
Yeah.
She unmuted herself.
Pallavi, share screen and unmute yourself.
Pallavi madam, you have to unmute yourself first.
Okay. So, sorry for the inconveniences. I would like to share a few glimpses of the activities done in the Smile Train Ortho Clinic. In our Smile Train unit, we have certificate courses in cleft orthodontics under guidance of Dr. Borle, Dr. Kamre, Dr. Srivastava, Dr. Puneet, Batra, Dr. Jaju, plastic surgeon, Dr. Niranjani, Dr. Bhola, and Dr. Yadav are our oral surgeons. Then we have MDT clinics performed every month, wherein the cleft team discusses over the formulating treatment protocol for the cleft cases and also the progress of the case. So this is my team with an ENT surgeon, plastic surgeon, Dr. Puneet Batra, the orthodontic team, Dr. Abhilasha Yadav, and the pediatrician, and the team how we are discussing the cases in the MDT clinics. We also have fellowship programs in cleft orthodontics and surgical orthodontics. So after the discussion of the role of orthodontist on various aspects of the cleft management, let's discuss the role of an orthodontist in the orthognathic surgery. The orthodontic surgery was first the name given for the orthognathic surgery, so it evolved in an orthognathic surgery. And we had some orthodontic limitations as a remedial measure under the envelope of the discrepancy that has led to the evolution of the new surgical techniques. During the development, the affected individual undergoes a series of periodic treatment approaches, affecting the nasomaxillary complex by restricting the growth. Though multiple procedures are taken up to normalize the growth and development, there is an hypoplastic maxilla. Few cases therefore demands a definitive surgical correction in restoring the near normal balance. And therefore, the orthognathic surgeries, when we talk about them, they are performed after the completion of the growth, when they are completed at 14 to 16 years in the female, while 16 to 18 years in the male. Despite the recent advances in the primary surgical techniques, about 5 to 10% have severe jaw discrepancies, which requires orthognathic surgery. So the indications for the orthognathic surgeries are the nasal obstruction and the sinus blockages, alveolar defect, velopharyngeal dysfunctions, chin dysplasia, and more often the maxillary hypoplasia. So first upon, there is an importance of the clinical evaluation where the familial nature of the facial clefting needs a thorough history. A detailed previous treatment history undertaken throughout the period of the development becomes very necessary. And also special attention need to be given to the psychological history, because that will help us to gauge the patient's expectation from orthodontic as well as the orthognathic therapy if needed. Therefore, a complete extraoral and intraoral assessment with suitable photographic records with the impression becomes mandatory. The casts that we take for the evaluation are categorized under Gosselin yardstick if they are unilateral cleft lip and palate, and the Baru yardstick for the bilateral cleft lip and palate. Now, the applicability of this yardstick is for anteroposterior, vertical, as well as the transverse assessment. If discrepancy is in the anteroposterior, the preferred surgery is leafodontostomy, modified leafod 1, distraction, and the mandible. Whereas the vertical indicates for a leafod 1 osteotomy with a down fracture, and transverse discrepancy requires a SARPing. The next comes the functional evaluation, which is of special significance and emphasized to obtain centric relation with a phase bow transfer for every patient undergoing an orthognathic approach. This provides a dual benefit of firstly, a total overview of the occlusion in the patient's craniomandibular relation, and secondly, assist in planning of the surgery. None other but important is the airway analysis in the cleft, where the few authors have also stated that in adulthood, the BCLP has a greater reduction of the nasal airway when compared to UCLP and the cleft palate only, while patient affected with UCLP and BCLP has decreased volume of the aeropharyngeal airways compared with the control group. Thereby, meticulous evaluation of the mandible for the setback procedures to correct the class 3 needs cognitive knowledge to differentiate between the mandible in the cleft and the skeletal class 3. So the difference between the skeletal class 3 and the cleft class 3 is as the maxilla in the cleft case, it is very important to evaluate the class 3s that appears with a different etiology in cleft as well as the skeletal class 3s. So the maxilla in the cleft patient is dysplastic as well as displaced posteriorly as compared to the cleft, as compared to the class 3 cases. The mandible in the cleft is often normal and mostly downward rotated, while the etiology for the class 3 is the mandibular prognathism. Therefore, the objective of the orthognathic surgery for the cleft case differs with that of the skeletal class 3. Therefore, the type and the variety is important to evaluate. So, the radiographic analysis plays a major role to evaluate the tooth number, the level of the alveolar bone, status of the bone graft, impacted missing tooth, morphology and anatomic condyles, defect size and extensions, and the skeletal discrepancy. And therefore, CBCTs and the other radiography advancements plays a major role. Along with the other analysis like Downs, Steiner's, Twit's, Schwartz, Burstone, even important for the surgeons is the counterpart analysis. The department has also come up with a new method to locate point ANS to determine the sagittal length of the maxilla that aid in the maxillary osteotomy. Also, most important is the simulation and the prediction tracing to assure that the plan is in right way. And therefore, the digital planning softwares are very important when we talk about the orthodontic surgery. Later is the evaluation of the graft being done, which can be done with a Berglund scale or a Chelsea scale. If there is a failed bone graft, each segment should be evaluated and treated individually in anticipation of the Lee-Ford segmental repositioning, and if needed, a regraft can be done. In a successful bone graft, the arch forms can be evaluated as an integrated unit. The orthodontic surgery with Lee-Ford maxillary advancement has been a conventional standard method for addressing the hypoplastic defect. The limitation of the Lee-Ford osteotomy has been attributed to the contraction of the maxillary palatal mucosa and the associated scarring. Other than osteotomy, Lee-Ford 1 distraction osteogenesis has also been undertaken when the sagittal discrepancy is considered beyond the envelope of the surgical repositioning alone. So therefore, it is very important to differentiate and have the cognitive knowledge regarding the distraction osteogenesis and the Lee-Ford. As we all know, with the DO, we have a long-term stability, rigid fixation is not required, and it is mostly preferred over the Lee-Ford with respect to the speech improvement and mostly advised in the growing patient and skeletal class 1 cases. It allows bone filling in the gap created, establishes a good occlusion and a treatment of choice for hypoplasia as compared to the Lee-Ford. Later comes the evaluation where after the surgery selection that when a surgery first and when a surgery later approach should be carried out. So the indication for the surgery first approach are the minimum crowding in the anterior teeth with a favorable curve of P, normal range of angle between the basal bone to upper and the lower incisors, and the advantages are the RAP phenomena, that is rapid acceleratory phenomena post-operatively accelerates the orthodontic tooth movement and shortens the treatment time. While the surgical later approach, the primary aim is decompensation and occlusal stability after the surgery to minimize the need of the surgery extension in the severe malformation. So, what are the objectives of the pre-surgical orthodontics for an orthognathic case? The surgical requisite is a well-aligned arch with well-established width and arch form and a stable occlusal table without interferences for the post-surgical stability. Severely crowded or impacted teeth should be carefully evaluated and the decision to extract should differ until the established form and width. The need for expansion is based on the arch structure and the predictive post-surgical occlusion. It helps in the increment in the arch length and the alignment. So the role of the orthodontist is such as the root orientation of the teeth adjacent to the surgical site must be changed. The position of the roots in the divergent pattern is done to avoid any inadvertent damage due to the surgical cut. Bracket reorientation or V-bend in the arch wire help to create a symmetric geometry. Lower arch alignment and plane should be addressed simultaneously. To best orient the post-surgical maxilla, the curve of P should be leveled and the absent lateral incisor space is orthodontically closed by the canine substitution. So after the gross discussion on the, let us see some few cases treated with the orthognathic surgeries. Okay, so this is case 1, a BCLP case with a skeletal class 3, concave profile, lesser maxillary length, increased mandibular length with a vertical growth pattern was categorized under Baru 4. Now the treatment plan was fabricated for the case wherein the pre-surgical orthodontics included extraction of the deciduous teeth, leveling and alignment of the arch closure of the extraction space, followed by the alveolar bone grafting to achieve the inclinations of the incisors to respective jaw bases, followed by the phase 2, wherein distraction osteogenesis of the maxillary advancement was done along with the setback. The phase 3 included post-surgical orthodontic with finishing and settling of the occlusion. After the post-orthodontic alignment and expansion, maintaining the arches still in a cross bite, the case was referred for surgically assisted distraction osteogenesis for correction of the maxillary hypoplasia. The distractors that are used are the alveolar ridge distractor, external midface distractors, CMF maxillary distractor, osteum maxillary distractor, and most commonly used in our institute are the indigenous distractor. I'll be discussing few of the cases treated with this tooth distractor in the upcoming slides. So this is the indigenous distractor fabricated with a Hyrax screw with the bands on the premolar and the molar, and the screw is placed anteroposteriorly to distract the anterior segment, as well as the posterior segment is distracted posteriorly. A mock surgery is being done, and this is how the appliance is placed intraorally. Surgical planning in collaboration with the surgeon is very important as per the requirement of one's case, and therefore it is a must, and we can here appreciate the results of the maxilla which is distracted anteriorly. A gap of 5 to 6 millimeter is being created distal to the premolar, which will be utilized further for the prosthetic implant. So this is how the case has been now. We can very well appreciate here the correction of a class 3 to a forwardly placed maxillary with an AMD. The correction of the profile is seen, advancement of the maxilla is there, and the length of the mandible is also corrected. After the distraction, the case is referred for consolidation with an ABG. The most preferred ABG is an iliac bone graft with a PRP. This decreases the rate of the failure and increases the stability and the quality of the graft being done. So this is how we can appreciate the corrections of the profile, advancement of the maxilla, decreased length of the mandible, and correction in the growth pattern is achieved. This is the second case of UCLP with a skeletal class 3 with decreased maxillary length with a normogathic mandible, concave profile, average growth pattern categorized under the Gosselin 4. A similar treatment plan was formulated for the case as that in the case 1, except that the BSSO was not done for the mandibular osteotomy. After the pre-surgical orthodontic alignment with the expansion, the patient was referred for the surgical distraction. These are the photographs showing orthodontic expansion with still maintaining the crossbite in the anterior section. And Leafoot 1 osteotomy for the distraction was done for the case, this time with a bone distractor. So after any osteotomy, the most important role is played by the splints for the stabilization, which are used for the upper and the lower jaws after Leafoot or after a distraction process. So what are the use of a single surgical splint and a double surgical splint? The single surgical splint is indicated in a single jaw surgery, whereas a double surgical splint is for a bi-jaw surgery. In a single surgical splint, either the maxilla or the mandible is corrected to the desired position and the occlusal splint is placed. There isn't a requirement for any intermittent splint, and a single splint dictates final position of both the jaws. Whereas the maxilla in a double splint surgical splint is first repositioned. Following this, an intermediate occlusal splint is placed. Mandible is then repositioned with respect to the maxilla, and the final occlusal splint is then positioned. So, as an orthodontist, the prefabricated acrylic occlusion split is left in the place for the 5 weeks. Patient is then educated about the application of the elastics and encouraged to remove the elastics intermittently to establish an early range of mandibular opening after the surgery. The orthodontist sees the patient within 24 hours of the splint removal to replace the maxillary sectional arch wires with the rigid continuous arch wires. So these are the result post distraction. The negative overjet is now corrected to a mild class 1 bimaxillary protrusion with no mandibular setback. Would like to share with you the another case with the AMDO. A UCLP case with a skeletal class 1 pattern, average growth pattern, straight profile, aligned arches categorized under class Gosselin 1. Phasebo records are mandatory and should be made for any surgical planning. For this case, unilateral distraction was planned as a right side was occluded very well. So, after the unilateral distraction was done, the lesser segment was distracted anteriorly and the case was referred for the alveolar bone grafting. The post-treatment shows a stable occlusion achieved and the prosthesis was given with no mandibular setback needed in this case. Another case used with an indigenous distractor was a UCLP case with a horizontal growth pattern, concave profile and a normographic mandible categorized under the Gosselin 3. Again, an indigenous distractor was fabricated, and here also you can very well appreciate the amount of the space fabricated or the amount of the space that we achieved distal to the premolar, which were later replaced by the prosthetic implants. So, even after with the associated advantages of the distraction osteogenesis, Lefort still remains a choice for many surgeons. It was Obvigesser introduced the Lefort osteotomy followed by the down fracture and mobilization, which was a key step, and he used the blocks of cancellous bone from the iliac crest to fill the horizontal and the vertical gaps. So coming to the cases which were treated with, which were operated with only the Lefort without distractions, a case of bilateral cleft lip and palate with skeletal class 3, vertical growth pattern, had a wide cleft defect, no crowding, the growth was completed and was categorized under Baru 4. Again for him, Phasebo record were taken, surgical setup was prepared, splint was fabricated for a uni-jaw surgery as mandible was in normal range. So this is how, after the alignment, the surgical cuts were given, maxillary osteotomy was done, and the splint was placed. After the surgical repositioning and alignment of the teeth, this is how the Lefort have done wonders in this case, and without a mandibular setback, the arch were stabilized and occlusion was achieved. This is the second case in unilateral cleft lip and palate with a skeletal class 3 with decreased maxillary length, increased mandibular length, a vertical growth pattern, wide defect in the left side, crowding present, concave profile categorized under Gosselin 5. Again, the same treatment modality and the same treatment plan was protocol was established for the patient, but this time what was added was a mandibular setback along with it. Arch expansion was done with an quad helix, alignment was achieved with orthodontics, and 2 surgical splints were fabricated for a bi-jaw surgery. So these are the results of the Lefort 1 osteotomy and the BSSO done for the case, wherein we have achieved the straight profile, class 1 molar and a positive overjet. So very wonderful work done by my surgeons. The last case I would like to show is again a case treated with the Lefort osteotomy, UCLP case with class 3, severe crowding, categorized under the Gosselin 5, and expansion was done with a NITA expander. After the alignment of the upper arch and the lower arch, the case was transferred to the oral surgery for the Lefort 1 osteotomy. So these photographs can show the pre and post treatment comparison done post Lefort and the mandibular setback. We have very beautiful results and patients are really happy and they are looking very beautiful. So after the surgical phase, the role of an orthodontist in the post-surgical management and the settling of the occlusion is the orthodontic maintenance of the surgical results and detailing of the occlusion are initiated 5 weeks of the initial healing after surgery. Teeth are ligated for acceptable overbite and overjet with tight intercuspations of the teeth, arch form maintenance, improvement in the dental and the muscular function. The orthognathic surgery triggers the osteoclastic activity and metabolic changes which may accelerate the post-operative orthodontic tooth movement forces, and therefore they should be well monitored. The placement of the extended transpalatal appliance is indicated post-retention and even post-prosthesis. So, I would like to conclude with a take-home message that the critical analysis and the pre-treatment planning is the key to success. Meticulous categorization and case selection for DO, AMD or leaf-foot osteotomies, the unijaw or the bijaw surgeries, surgery first or surgery later approach is required depending on the objective of the case to be treated. Post-surgical orthodontists play a major role in the long-term retention and stability. I really appreciate your patient listening. Thank you. Last but not the least, I would like to pay my tribute to the stalwarts who serve the society with their unconditioned love, Dr. Hiji Adenwala, Dr. Josna Murthy Madam, and Dr. Satish Kalra sir. Thank you, everyone.
Thank you, Dr. Pallavi, for an enlightening session. And there are a few questions for you. The first question is that you showed some cases with AMD. Now, in AMD, the question is that how stable are the results? Because you're pushing this premaxillary segment or the dentition towards a lip which is highly scarred. So, how stable are your results with AMD?
As compared to the leaf-foot one, as literature I have also said that the results of the AMDs or the distraction osteogenesis are more stable than that of the leaf-foot, because it is a slow stretching of the tissues which helps in the stability post-surgical.
What is your preference for the bone which is formed? How do you maintain that area? Because there is a possibility of relapse to happen. So do you place an implant there? Do you
yes, the space that is, yes sir, the space that is created after the AMD, after the distraction, we maintain the space with an prosthetic implant that is replaced with a prosthetic implant.
Right. And the next question is that bone graft, you in your center, do they like to do it with the osteotomy, or if there is a need for bone graft, that is done first and the surgery is done 6 months later?
See, that will depend depending on the defect in the alveolar in the cleft segments. So if, because every surgery has some or the other limitations, if the osteotomy has been done and there is no gap in between the two segments after the osteotomy, or let it say after the distraction, so after 3 months we can very well go with a bone grafting. And in some cases, bone grafting is also not required if there is a good stable bone over here after the distraction and even after the leaf-foot. In few of the studies, they have also stated that to pre-graft the alveolar defect and then distract or then slowly distract the bone so that the bone will be compressed in that area and may also give a good results. So this depends on the type, the amount of the cleft defects, the type of the surgery that you are performing, the age of the patient, especially where you need to do the alveolar bone grafting for the canine eruption, that needs a grafting first, followed by then distraction.
Right. Now, what is the duration of wear of surgical splints?
5 months.
5 months. And how do you actually decide whether you want to do distraction or osteotomy in a particular case?
Yeah, this is actually a very good question. Between the cases to be undergoing distraction and in the first objective is advance the maxilla with a leaf posterior discrepancy is more, needs a stepwise advancement. In few cases, even after the distraction procedures, after the growth completion, the leaf have also been done.
There is a question on what and how soon do you start molding the callus in distraction cases? How soon do you start molding the callus in distraction cases?
Hello? Hello?
How soon?
Hello?
Can you hear?
Yes, sir. Yes, sir.
How soon do you start molding the callus in distraction cases?
3 weeks.
3 weeks, right. So, dear friends, it's been a highly enlightening session. I am very thankful to all the speakers, Dr. Ashit, Dr. Renu, Dr. Pallavi, and of course, Dr. Maria. It was really, really nice, interactive, and I've got so many good comments in the chat box praising that the presenters actually took a lot of effort in making this wonderful presentation. On behalf of the Indian Cleft Palate Society, I'm thankful to the President, Dr. Krishnamurthy, and to the Secretary, Dr. Atul. So I request Dr. Atul to take over and propose a vote of thanks. Dr. Atul, are you there?
Well, from the behalf of ISCLPCA, I would like to thank all the faculty for a very, very comprehensive session on cleft orthodontics. Thank you, Dr. Maria, Dr. Ashit, Dr. Renu, Dr. Pallavi, for sharing your experience as well as insight with the audience. I would like to tell you that this was a very well attended session, more than 310 participants live. And I think many of us will see the YouTube channel also down the line. And from the participants' perspective, I would like to tell that I think you should subscribe to our ISCLPCA channel, because all the cleft related presentations will be uploaded on this channel. And by subscribing, you will be aware of all these activities which we are doing. And I would also like to thank Dr. Puneet for being moderator for this session, and our President, Dr. Krishnamurthy, for chairing this session. Thank you one and all, and thank you all the participants. I think you would have gained something out of this excellent presentation. And I'd like to tell you that this presentation will be available on YouTube for years to come. Thank you very much.
Thank you, Dr. Atul. In fact, you are the soul behind this program. You have done so much groundwork behind the scene. We are really thankful to you, sir.
Thank you, sir.
Dr. Praveen, you